Good evening and welcome to this joint webinar from the Royal College of Surgeons of Edinburgh and the Association of Surgeons of Great Britain and Ireland. ASGBI is the UK Specialist Association for General and Emergency Surgery, or EGS. ASGBI is 100 years old this year, but was predated by the last UK pandemic of this scale. It's been quite a difficult 2 months for us all. We've seen remarkable changes to EGS practice as we prepare for the potential overwhelming of our healthcare system by clearing the decks and planning to avoid surgery where possible. In fact, we've had a complete paradigm shift in UK surgery, having to consider outcomes in terms of populations and staff, as well as the patient in front of us. Early outcome data have suggested that COVID-19 increased surgical mortality significantly, thus confirming some of our fears. This evening, we're going to look at some of the many challenges that COVID have caused us in surgical practice. We're going to explore those with the help of the experts, and we're going to look at some of the solutions that are on offer this evening. We're now past the first wave peak in the UK, but COVID is clearly going to be influencing EGS care for quite some time. As we move into this next phase, our return towards previous practice is going to depend very much on local factors, probably particularly PPE, which both ASGBI and the Royal College of Surgeons of Edinburgh have championed. Our three experienced clinicians this evening come from very different areas with very different experiences. They'll be able to discuss many topics relating to COVID and EGS. We're going to start with three short presentations on areas of EGS which are common and which have seen significant clinical change. Let's meet our three speakers. Each will give a short talk while you fire in your questions as indicated on the website. We'll try to answer as many of those as we can. First up will be Mr. Christian Makutovic. He's going to talk on acute biliary surgery and the laparoscopy question. He's a consultant general and HPB surgeon in Manchester Royal Infirmary. He's the director of the scientific committee of ASGBI and is extremely experienced in COVID. Had a tough time at Manchester Royal. Christian.
Thanks, Ian, and thanks to the Royal College of Surgeons of Edinburgh for giving me this opportunity to share my experience and our pitfalls and things that we've gone through during this time. Next slide, please, Abby. So I've been told to give a little bit of a scene setting. So the virus outbreak was first reported the back end of last year, November, in Wuhan, China. And we were certainly looking over this with interest to see if there was any chance that it was going to come to us. And then December, the WHO named it SARS-CoV-2 or COVID-19, which is what we all refer to it as. The pandemic reached our shores in February, March. And it was really in March, a weekend in March 2020, that the reports that the London hospitals became overwhelmed with a 12 to 17-fold increase in severe respiratory patients requiring intubation. And it was this really that triggered the massive expansion of ICU beds nationally and a real push for discharges from hospitals around the regions to limit EGS admissions and to change our practice ready for this wave or surge of patients coming to each of our hospitals. Next slide, please, Abby. So in March and early April of this year, the juniors, certainly our juniors, were pulled into COVID rotas where they were repatriated to either intensive care or COVID wards or indeed the emergency department. And this left us very short of staff, and new surgical consultant rotas had to be developed that involved days, night shifts, plenty of rest days to try and make sure that we don't all get fatigued. There was an obvious reduction in elective activity, mostly to try and reduce the number of patients we got in our beds, but also because a lot of theatres were being used as extended ICUs, and a lot of hospitals around the regions had bookable tables for cancer mainly. Laparoscopy was feared as an aerosol generating procedure, and we're going to touch on that a bit later on in the talk as to why that was. And obviously we had lots of reports of PPE being in short supply, and we've certainly seen that all over the news. As I mentioned before, there was a real push for conservative management of surgical patients where this is safe. And the two main conditions that this has really shown big differences in the management of acute appendicitis and gallstone disease, and we'll go on to those now. Next slide, please. So acute biliary surgery pre-COVID, we all knew the NICE guidelines published in 2014. Acute cholecystitis was treated by an emergency laparoscopic cholecystectomy within 7 days, and anybody with gallstone pancreatitis had a laparoscopic cholecystectomy on index admission. And we all know that that's the best way to manage our patients. There has been a huge change during the COVID pandemic, and we have seen a massive reduction in gallbladder surgery. Now, a lot of this has been steered by the fact that laparoscopy was deemed aerosol generating, or feared as an aerosol generating procedure. And therefore, a lot of clinicians had a push towards treating these patients with intravenous antibiotics, discharge them home, and admit them electively for a delayed cholecystectomy, like we all used to 10 to 15 years ago. There has been an increased use in cholecystostomies for those patients who are unwell or unfit for surgery. The chocolate trial showed quite significantly that cholecystostomy tubes are not the best thing for our patients. They increase the morbidity and mortality. And so I'm not a huge fan of these, but we've certainly seen an increase in this. And for patients that haven't settled down, we have opened them up and performed an open cholecystectomy rather than a laparoscopic cholecystectomy, which is what we're used to. So what implications might this have for biliary surgery in the future? Next slide, please. So I've broken this down into the three main conditions that we treat, and this is by no means evidence-based. This is my thoughts on what possible future implications there could be, and we've certainly seen some of these already. So I think patients with biliary colic will have a substantial wait for their laparoscopic cholecystectomy. We're certainly not doing any day case surgery yet, and I fear that there may be an increased number of patients presenting with acute cholecystitis. In terms of management of acute cholecystitis, I certainly think that we're going to see more cases of Mergency syndrome, and this is an MRI scan of a patient with Mergency showing pinching there of the common hepatic duct. So we've certainly seen this, and we've certainly seen an increased number of patients who have come with complications such as liver abscesses. And I think their surgeries in the future will be a little bit more complicated because they've got a pathology that's not been treated as we normally would. In terms of gallstone pancreatitis, we've certainly seen patients unfortunately represent with further gallstone pancreatitis, having not had their gallbladder out. And I'm just wondering whether, because of this, we might see an increase in number of patients with common bile duct stones. We're certainly seeing increasing number of patients with the recurrent attacks. And these are all things that we are going to have to tackle in the future when this settles down. Next slide, please. So what about laparoscopy? So the fear about laparoscopy was first mooted by the Italian surgeons in Lombardy who feared that the aerosolization of virus particles is probably worse with laparoscopy and with energy devices such as ultrasonic dissectors or bipolar diathermy. And there were early reports that viruses were isolated from feces, and it wasn't really until a case report in the Annals of Surgery found peritoneal fluid had 10 times the amount of RNA than a nasal swab in a COVID patient. This patient had no perforation of their bowel, no bowel resected, and it was just a simple band adhesion and that underwent a laparotomy. So the peritoneal fluid confirmed that the virus was there, and it was quite concentrated. It's important, I think, to think that the risk-benefit of patients for laparoscopy has to be taken on an individual basis. And I certainly think that we should start thinking about the huge benefit in patients who are obese with a appendicectomy, which are often quite difficult to do open. And we've certainly seen complications of patients that have come back who have got intra-abdominal sepsis after having a ruptured appendicectomy, not fully washed out at open surgery. There is a clear benefit in length of stay with laparoscopy, and certainly there are lots of calls for laparoscopy to be reintroduced. I know that some units have never stopped it, but I think the overwhelming majority of units did put a pause on it. It's important to protect the surgeon, and Claire's going to go through PPE. I think it's important to have that discussion about what's appropriate in PPE, and I've put here the link to the Association of Laparoscopic Surgery of Great Britain and Ireland, who published a position statement, and I'll go through the points of those now. Next slide, please, Abby. So they recommended, this is a truncated version, they recommended routine COVID-19 testing, and certainly we're doing that for all electives and now all emergency patients. They've recommended full PPE for all theatre staff, so that's the full PPE as though it's a COVID-19 patient. They recommend designated clean areas for elective cases, and we're certainly, most hospitals are certainly well on the way in doing that. The next bit is the more difficult aspect of laparoscopic surgery, and I think there is a cost implication with this. The use of closed circuit smoke evacuation with ultra-low particulate filters. These are often filters that you see on an anesthetic machine, and they're the small round things that can attach onto tubing. Now, in my hospital, we can't restart laparoscopic surgery until we have some of these filtration devices. We don't have closed suction. We don't have a way to suck out all the gas yet. They recommended very small incisions to have small, careful port insertion to try and minimize that aerosolization of the contents of the abdomen, and to use smaller ports if possible. We certainly have balloon ports, and they certainly do reduce gas loss, and certainly they are recommended by the ASGBI. Minimizing instrument exchanges. This was one of my fears about laparoscopic surgery. When you introduce and take out instruments, you get the small little puff of gas that comes out at the port when you do this, and there's no real way to stop that from happening. The use of lower intra-abdominal pressures at laparoscopy, 12 millimeters of mercury or lower, and obviously minimal use of energy devices, and they count that as diathermy, bipolar, or any ultrasonic dissectors. And finally, closed evacuation of gas at the end of the procedure. And these are all the techniques that they say would make it safer. In terms of how that happens, I think shared learning from hospitals is really important, and I've certainly been in regular contact with our local hospitals, and certainly the ones that have been doing laparoscopy, to share ideas on how to make it safer. And that's all from me. Next slide. Thank you very much.
Thank you very much, Christian. That's a great start. I see some of the questions are already piling in for you. We'll look forward to coming to those after the next two talks. The next speaker, great pleasure to introduce Cleo Kennington, who's a consultant emergency and upper GI surgeon at St George's in London. She's the London representative for ASGBI and lead for sustainability. She's an acute care surgeon and editor of the English College's Bulletin on EGS. She's going to talk to us about the management of appendicitis during the pandemic. Thanks, Cleo.
Thanks, Ian. So, as Ian said, I'm going to be talking about appendicitis during the coronavirus pandemic. Can you move to the next slide, please? So when the COVID pandemic hit the UK, the intercollegiate guidance was issued on the 27th of March. This came jointly from all the surgical colleges and associations. And as appendicectomy is one of the most common indications for emergency abdominal surgery, you can see that it is listed, they have specific guidance for these patients. But the recommendations were the opposite of the then current practice, to use conservative management and open surgery versus operating and using laparoscopic. The reason for these changes were to protect patients by keeping them out of hospital and to protect staff by avoiding operating on patients with COVID, but also to free up operating theatres to allow the ventilators and the anaesthetist to be used for the COVID patients. However, it's important now that we consider the health of patients with non-COVID disease during the pandemic, as there's increasing evidence that the number of excess deaths that are being seen are not all explained by patients with the virus. So we need to make sure we're providing quality treatment for all our patients. So it's time to consider what the evidence is for these guidelines and how we should be practicing now that we've passed the peak. And then also think about what we need to do if there's another surge. But next slide, please. There's been much debate regarding the operative and non-operative approaches to appendicitis. This study from the BJS in 2016 is a meta-analysis of 5 randomized controlled trials looking only at non-perforated appendicitis, but they included over 1,000 patients. And here they found that of the 550 patients in the antibiotic arm, there was a 91.5% success rate at 1 month. But within a year, 22% had recurred. And this is critical for COVID because while our patients who were managed conservatively during the peak allowed those anaesthetists to be freed up, we have to be wary now of these 22% that may return, especially if this occurs during a second surge. Also, most studies on conservative management of appendicitis have been looking mostly at non-perforated appendicitis. So this won't include the all-comers that we see during the pandemic. Next slide, please. So next is to consider the risks and benefits of laparoscopic versus open appendicectomy. We've already heard the risks of laparoscopy with coronavirus patients, but do these risks outweigh the benefits of an operation in a patient with suspected appendicitis? So this is a Cochrane review of the evidence for laparoscopic versus open appendicectomy from 2018, and it looked at 85 studies involving nearly 10,000 patients. And they showed that laparoscopic surgery showed an advantage in many aspects. And most importantly, during this pandemic, is that it showed a reduced hospital stay. So if there is a concern for COVID, as Christian mentioned, it may be important to avoid laparoscopic surgery. But if you could demonstrate by swabs and by CT of the thorax that this patient is unlikely to have COVID, then laparoscopic surgery can have great benefits, especially in the obese patient. Next slide, please. So I've discussed the changes that were mentioned by the intercollegiate guidance, but I haven't discussed diagnosis of appendicitis. The negative appendicectomy rate in the UK is often quoted as between 15 and 25%. And during a pandemic, we would not want to be operating on someone unnecessarily. So diagnosis is critical. Several recent publications have demonstrated that countries with higher rates of imaging have lower negative appendicectomy rates. And data here is from a study published in Colorectal Disease in 2016, which showed that the UK had a negative appendicectomy rate of 20% compared to 3.2% in the Netherlands. And they demonstrated a much higher pre-op imaging rate of 99% in the Netherlands. They use first ultrasound and then CT if the result is unclear. Similar findings have been demonstrated in the US, where CT is the first line of imaging, and their negative appendicectomy rate was reported in one series at 1.7%. So during COVID, while a CT scan of the chest is recommended if undergoing emergency abdominal surgery, as Claire is going to discuss further, it seems sensible to use CT of the chest, abdomen and pelvis for diagnosing the appendicitis during these times. Next slide, please. So this is a slide from the COVID Harem group. This is a UK-wide audit of outcomes of adult patients with symptoms of appendicitis during the COVID pandemic. They audited how the intercollegiate guidelines have been implemented and their impact. It was established amazingly quickly and currently has 60 sites with more than 500 patients entered. From the data so far, they've found that the majority of patients have undergone CT, and many were managed conservatively and their surgery performed open. If your hospital's not already submitting data to COVID Harem and you're interested, please email the team at covidharem@asgbi.org.uk, because their data is being collected retrospectively. Next slide, please. And finally, I just want to finish with data from my hospital that was used for the COVID study, St George's in London. And I'm thankful to my trainees, Sarah Hudson-Phillips and Zach Binnicum, for this data. We've had a total of 21 referrals for right iliac fossa pain, which is down from 58 during the same time period last year. And of those 21, only 2 were not diagnosed with appendicitis. The ratio of male to female among patients with appendicitis is predominantly male, which is as expected. However, last year among our referrals, of that 58, 56% were female. And there has been discussion that the reason for the low number of attendances in the hospital was related to patients staying at home with delayed presentation. However, our data doesn't support this. Our data shows the patients presented promptly with an average of 1.4 days after symptom onset, which is quicker than the same time last year, which was 5.6 days, suggesting that patients with surgical disease were coming to the hospital appropriately, whereas those with non-specific symptoms that settled spontaneously did not present. So to conclude, while the intercollegiate guidance was very useful during the peak to allow capacity for the COVID patients, on a patient-by-patient basis, there may now be times to consider returning to standard treatment to avoid complications for those patients. However, pre-op imaging is helpful to avoid unnecessary surgery. Thank you.
Thank you very much, Cleo. That was great. And we'll move on to our third speaker. One of the major paradigm shifts of the last 3 months has been this change about balancing the needs of the patient in front of you with the need to avoid population spread, to care for the population and also to care for the staff. And one of the issues has been PPE, as you all know. Claire McNaught is going to talk about staying safe in EGS. Claire's a general and colorectal surgeon, well known to many of you. She's been on the Edinburgh College Council for 6 years, a regional advisor in Yorkshire. She's a college examiner, chair of the Younger Fellows Committee, and she's editor of Surgeons News. Claire.
Thanks very much, Ian, and welcome everyone in this lovely evening. So I've been asked to talk to you tonight about staying safe in general surgery. First slide, please. And I think the best place to start is actually to try and quantify what is your risk. And I thought I'd share this data from the Office of National Statistics. Over a 2-week period, at the beginning of May, they swabbed 10,000 patients. And this is English data, I'm afraid, but they reckoned that about 148,000 people were infected at that point. And if you're a hospital worker, your risk was 5 times that of someone in the community. So it's not an insignificant risk. And we've all seen very high levels of intra-hospital transfer of COVID, unfortunately. Now, the thing we worry about most, however, is death. And sadly, there's been over 180 people have died, NHS frontline workers. But I wanted to show you some work by Tim Cook, which he presented a few weeks ago about the first 106 deaths in hospital staff. Of that, of the 17 doctors in this group, surgeons were the top speciality, reaching 5 surgeons. But it was interesting, there was no anaesthetists or intensive care doctors or nurses in this first study. What we did see quite clearly, however, if you were male or from a BAME background, then your risks were significantly increased. So next slide, please. So what do we do to try and stay safe? Well, really, I think there's a 3-pronged approach that you have to take. The first thing is you have to identify the infective patients. The next thing is using your PPE correctly and at the right time. And the third strategy is to minimise your viral exposure. And I'm just going to take you through these aspects over the next couple of minutes. Next slide, please. So identifying the infective patient, I think we're much better at this now than we were at the beginning. I'm sure if you all think back to how chaotic it was when it first hit us, we're really much better now. People come in and they're screened immediately with their questionnaire and they have a temperature taken. I just want to talk a little bit, though, about the atypical surgical patient, because there are some atypical presentations of COVID that might land on your ward. So, for example, the patient with abdominal pain, diarrhoea and vomiting, about 10 to 30% of patients with COVID can present in this fashion. Many have no respiratory symptoms whatsoever, and they often have a more severe disease course, so you have to watch out for them. I think the other patient group that we've seen is the people with abdominal pain and altered liver function tests, and it's nothing to do with gallstones, it's to do with the cholestasis that the virus can also cause. And the sort of third group that we might be called to see initially, that we might not realise is COVID, is the critically ill patient who comes in with the acute abdomen with the mesenteric ischemia and perforation. I think it's important to note that COVID patients, critically ill patients, are presenting like this. They think it's small vessel thrombosis. And indeed, in a study of ITU patients, about 30% have abnormal abdominal CT scans. So just something to keep in the back of your mind. The patient, they may look like they've got an abdominal problem, but in fact, they've got COVID. Next slide, please. So how do we tell if they've got COVID? Well, most organisations in the UK are using PCR. You have the nasopharyngeal swabs. If you're lucky enough to work in an organisation, you've got in-house testing, you can get that result in 4 hours, which can be helpful. But if you don't, it can take up to 72 hours to get that result back. So that's not particularly helpful in an emergency situation. In the States, they're doing a lot more point of contact tests. It's slightly different type of technology, and they're great because they can get a result in about 13 minutes. But they're not widely available here yet in the UK, or I'm sure that's where we're going to head. Initially, we thought a lot about doing chest x-rays on patients, but even in symptomatic patients with COVID, more than half of the chest x-rays are normal on presentation, so they're not hugely helpful. But I think one thing that has been helpful, and particularly in our very sick patients who have to have an abdominal CT for an acute abdomen, the Royal College of Radiologists agreed to do a CT chest, and that's very sensitive at picking up current COVID infections. It's no longer indicated, however, in elective surgery. Next slide, please. So what about PPE? I'm not going to dwell on this too much. I'm sure we'll talk more about this afterwards, but you've all seen the recommendations in this poster before. There's actually 2 operative channels in this, but I would say to you all that I think at the moment, particularly as parts of the country are still going through quite high levels of infection, you should treat them all as aerosol generating procedures. In most organisations, the acute patients are being intubated in theatre, so aerosols are being formed. So the whole team should be in full PPE, including FFP3 respirator masks and all the other stuff that we routinely use. I don't think we can compromise on this at the moment. Next slide, please. What about minimising our exposure? Well, as everyone's alluded to, we're starting to get some results from COVID that suggest that patients who have emergency surgery then get COVID do very badly. And the ones that do particularly badly are the ones that are at higher risk of COVID, really, which means they're male, they're over 70, and they've got comorbidities. And I think if you've got patients coming through the door in that group, you really want to try conservative management wherever possible. But when it's not possible, then and operations are appropriate, I think then you have to give individual consideration to each patient about which approach to use. And I think it's absolutely acceptable to do a laparoscopic appendicectomy in an obese 50-year-old man rather than doing a laparotomy, because you'll go home the next day rather than stay in your ward for 5 days with a terrible wound. So I would say that those decisions have to be made on an individual patient basis. The other thing I think that's all worthwhile looking at, I like the checklist from Lifebox. There are strategies that you can use before the operation, during and afterwards to try and minimise viral exposure, not just for yourself and the patient, but also for all the members of the team. For example, I think the team briefing has become even more important now. You know, making sure you've got all the kit in theatre that you're going to require is really important, so it stops runners having to come in and out of theatre and opening the doors and spreading viral particles if they're infected. So that's a nice checklist for you to use if you like it. Next slide, please. So we've talked about all of these things, but is there any evidence that actually by doing all of these things it makes us safer? Well, we do have some anecdotal evidence, and I'm very grateful to Dr. Kumar, who's the president of ENT UK, for sharing this data with us this evening. As you know, very sadly, one of the first surgeons who died of COVID was Mr. El Harani, an ENT surgeon. And so the ENT UK asked all their members to do a survey to let them know if they had COVID. And actually in the first month, 54 of their members did have a COVID infection. But if you see where that red line is, that's when the guidance came out for the new guidance in PPE, and also new guidance about operative approach. And if you take the normal incubation time of COVID for, say, 5 to 10 days, after about 10 days, they've had absolutely no new cases of COVID-19 infections in their surgeons. I think that's really quite powerful data, which does suggest that if you're using your PPE, if you're thinking about what surgery you're doing to minimise the risk, you can keep yourself safe. And I think it is also interesting that to date there's not been any ITU doctors or anaesthetists have died of COVID, despite the fact that they're in the highest risk environment, and that's got to be PPE. Next slide, please. Now, this is a question that everybody's been asking me. At least 50% of the panel have had COVID. I'm not going to tell you who's got rubbish hand hygiene, but the question is, if you've got COVID, are you immune? And there's a nice paper in JAMA last week that is trying to answer this. The short answer is we don't really know. What we do know is most patients do develop neutralising antibodies. That's why the plasma studies seem to have been successful. But whether or not they give you prolonged immunity is really unknown. We're kind of hoping that it's going to be a bit like SARS, which will give you a good immunity for 2 years and up to 6 years. And if you do get a reinfection, then it tends to be a less severe infection. But just having antibodies doesn't mean that you are immune. So I think at this stage you can't bin the PPE if you've had COVID. You must be just as careful as ever. One really interesting point in this paper is that they said that to date there's not been any confirmed human reinfection. Now, there are people who've had positive swabs down the line, but they think that's related just to very, very low levels of viral RNA, but not actually viable virus. So, and in fact, I think today there's just some guidance out about how you actually treat these continual positive healthcare workers, what you actually do with them. Next slide, please. So I've talked to you in the last few minutes about physical health, really. I don't know about you, but I'm going crazy with lockdown, and I'm seeing lots of unusual behaviours in all the members of the kind of extended team at the moment. You know, being a healthcare worker is a very difficult career. We know from last year, the report from the BMA, that there's very high levels of burnout. And now we've been asked our whole lives have been turned upside down, and we don't know what to do with ourselves. So I'm particularly worried about our trainees. I mean, a lot of them have had their career progression stopped. And I'm also very worried about our colleagues who are having to shield at home. I think they must be feeling very isolated at the moment. So what I would say to you all at this time is that I think you have to look out for symptoms in yourself and your colleagues. I think we need to be really kind to each other at the moment because we're living through very, very difficult times. There is help out there. We've put some links on the website tonight, and the BMA have got a good website just people you can call and anonymously if you need to have help. And we're hoping that we're going to have a couple of wellbeing webinars on this website in the next few weeks. Next slide, please. So just to summarise, final slide. Can you stay safe? I think you can if you're meticulous about identifying infected patients. you're using your PPE appropriately, and you're minimising or thinking about your viral exposure rates. Thanks very much.
Thank you very much, all three of you, for excellent talks and a very helpful note to finish on, Claire. Thank you for that. Got quite a few questions here coming in. Let's just pop straight back to Claire, so as not to give her a moment's rest. A couple of people have asked, is PPE mandatory even if the patient test for COVID-19 is negative? We'll go around the panel and see what you think about that, and maybe extend that out into where do you think we're going with PPE? There are one or two moves internationally to lessen the amount of PPE, but what do you think about that in the negative patient or the test negative patient?
Well, I feel at the moment that our tests aren't good enough. They're not, sensitive enough now to actually, to tell you that. As I say, when they were the PCR that we generally use, when it was first brought in, is about up to a 30% false negative rate. They suspect that now is down to 10 to 15%, but you're still getting it wrong in at least 1 in 10 patients. So I would be very, very cautious about that, particularly when actually we're still seeing in parts of the country some very high infective rates. So I think it's far too early to start to have the discussions about reducing PPE. I think there's 186 deaths in healthcare workers. There's 186 good reasons to use PPE.
Thank you. Cleo, do you want to unmute?
I think the way you ask the question is, should PPE be mandatory? And the way I would answer that is to look at PPE for other infections, for example, HIV, and we don't have mandatory. It is not compulsory for us to double glove, so I don't think it should be compulsory yet for us to wear PPE in theatre. I agree with what Claire has been saying about that it is beneficial, and to protect ourselves we should be wearing it. But I don't think mandatory is the right way of saying it.
Okay, Christian, would you agree with that?
So I would slightly disagree with that in that comparing it to HIV is a very brittle virus that doesn't last very long, for seconds in fact, outside the body. I'll just reflect a thing that happened in our hospital and echoes what Claire said actually. So we had an elective resection who self-isolated for 14 days, had 3 negative swabs, CT chest, all saying that it's negative for COVID. And on the day of resection, all the staff thankfully had full PPE with the FFP3 respirator mask and goggles and face shields. And at the end of the case, one of the ODPs came in to say that the 4th swab had tested positive for COVID. And actually the entire theatre team would have been completely exposed to COVID without them even knowing, had they not used full PPE for that case. I think it's too early for us to relax our PPE standards, because Claire's very nicely shown that since they were introduced, we've not had any surgical deaths in my hospital. We've had no consultants go off with COVID. They've not caught it from any patient or from fomites. So clearly we're doing something right, and the PPE that we're using is obviously protecting us enough.
Mm-hmm. And your conclusion on the ENT and other data, Claire, was you're quite firm about that. Do you want to comment further, and maybe the other two would like to comment on that? Then we'll go to some 2 or 3 questions from the audience.
I think the evidence is anecdotal, Ian. It's not set in stone. But I think if you actually look at all our departments, everybody who got COVID really got it very early on. And I remember going down to A&E and there was no PPE, and seeing and patients weren't being stratified by risk. And I was asking to see acute abdomens and were coughing all over me. Quite clearly now they had COVID. I soon learned that. But I think now we're much better at that, and I think that we are seeing less staff being affected. And that's really important now as we go on to try and re-establish elective care, because we know that from the Cambridge study that there's 3% of the staff are asymptomatically infected. So actually by wearing PPE, not only are you protecting yourself, you're protecting the patient because from you, essentially. So I think for two good reasons, both ways it works to protect the patient.
Okay, do either Cleo or Christian want to comment further? Yeah.
I'd agree with that. We actually did a study of staff in our hospital after an outbreak. We were seeing decreased numbers of patients with COVID, and then had a sudden surge of COVID patients on a ward. And when we tested all the staff, 14% were asymptomatic carriers. So we are almost like a petri dish. And I agree with Claire. We are not only protecting ourselves, but we really should be thinking about protecting our patients for the ones that don't know they have it.
That's a good point to move to one of the first questions that came in, which actually encapsulates quite a number of the issues that we've talked about are we defending the patient, the staff's relatives, etc. And this is about, first of all, the questioner says, the problem here is there's almost no real and reliable data to say that laparoscopic appendicectomy, cholecystectomy are not ideal in the COVID era. In their area, they've carried on doing them all without regret, but obviously without published data the other way either. And they quite rightly make the point that open surgery for those conditions have, in normal times, fallen out of favour. What do you think about this thing about having no data? It's quite unusual, isn't it? Here we are, first time we've been potentially overwhelmed, and it's with a disease we don't have any data on. It's quite a challenge, isn't it? But what do you think about this thing about proof of harm versus absence of evidence? Do you have any comments on that? Christian?
Yeah, I'll kick off with that. So I think we'll look back on this and realise that the laparoscopy thing was a knee-jerk reaction based on no data pertaining to COVID itself, but extrapolated data using other viruses, SARS, HIV, hepatitis. And I think they were done with good reason, or they were good with good intentions. However, I think we will look back and think that the pause in laparoscopy was the wrong thing to do. But it was every society. SAGES, ASGBI, ALSGBI didn't really say anything at the initial outset. So when you have international societies raising the question whether laparoscopy should be used, then the knee-jerk reaction is clearly, well, we'll be defensive because we're, conservative. We'll be defensive and we'll just see if there is any harm. Now, I think there's enough laparoscopy going on that with no increased risk to surgeons that we should all start thinking about reintroducing it. I certainly am. I know you are already, Ian, in your place, but I think the PPE thing is necessary. I'll be interested to know whether the respondent from up north had full PPE during those laparoscopic procedures, because that's one thing that we are struggling in having the enough PPE to do lap everything. That's one thing that we will struggle with.
Okay. Leo, do you want to comment on that?
I agree with Christian. Is that I think there isn't evidence that that we should be avoiding laparoscopy, and there's plenty of evidence that we should be doing it pre-COVID. So I think it's time to cautiously reintroduce it, looking out to see if any evidence comes around.
With PPE?
With PPE, yeah, certainly.
Claire, do you want to add anything further?
So I just think that hindsight's such a wonderful thing, isn't it? Every day of my job, I wish I had more of it. I think if you go back to the very beginning, it was the viral aerosol exposure and the very, very high. We realised quite early on that people who were exposed to very high viral titers seemed to be having a worse illness. So, and at that point, it was a very reasonable assumption to make that actually laparoscopy was an aerosol generating procedure. And that's the same reason why endoscopy was stopped immediately. As the science has got a bit better, we're starting to sort of come back on that and saying, well, maybe it isn't, how they can say endoscopy's aerosol forming, but colonoscopy's not. I'm trying to work that one out myself every day because I'm usually covered in this stuff when I finish a colonoscopy list. So I think that we're still learning a lot. I think the original call that was made was absolutely correct.
Mm-hmm. One of the questions coming in related to this is the fear of running out of FFP3 masks. Mm-hmm. And I don't know what country, because obviously this is an international audience we've got that the questioner's from, but for UK practice, if we don't have the kit, I guess the advice would probably still be not to proceed with laparoscopic surgery apart from in very exceptional circumstances. Would you agree with that, or would you disagree with that? Christian, you look uncertain.
Well, we've had a number of FFP3 masks, two of which I failed my fit test on, and I was only able to make it work on one, probably something to do with my round face. So there's been a real shortage in the one that fitted me, and I have had to do an operation with a mask that wasn't fit tested for me. Or rather, I failed the fit test on it. So I think the patient needed an operation. There was nothing I could do about it, and I tried everything to minimize any risk to myself. But I do think that shortage of PPE regionally is a thing. I've certainly had an experience. They've subsequently got that mask back in, so thankfully I've got that. But I think there will be shortages regionally.
Mm. So one of the other colleges has been quite assertive in indicating that if you don't have kit and don't feel safe, then the onus on you to proceed is certainly much less than it would be normally. But the issue of other staff in theatre, have you changed the way you talked about the sign-in, Claire, as being a way of really enhancing how we work as a team, particularly if you have masks and visors on and you can't communicate? What about consent from the rest of the theatre staff who may have elderly relatives at home, etc., for how the procedure's done or what steps are taken? Any thoughts on that, Claire?
So I think, I think as your role as a surgeon, it's your patient. I always feel comes first, and then it's your team, and then it's yourself. And I think I've certainly, if I think I have to wear full PPE, it means that I think every member of the operative team who's in theatre with me should be in exactly the same. Because why should they take any more risk than the one that's actually standing at the table? So we've made that absolutely standardised. I have to say, in our organisation, we haven't really had a problem with the respirator mask. I have to say, congratulate them. They've been very good at actually making sure we have had that. Where they've limited it, what we've really had to limit is trying to things like endoscopies, and where we just haven't. We're trying to get some elective endoscopy restarted, but we have to very carefully monitor the PPE that we've been using. So they've really always kept a store for the acute emergency surgical patients, but someone's had to pay the price, and unfortunately it's been the diagnostics that have suffered.
Okay. There's lots of questions coming in about details of COVID that we'll come to if we've time. I'd like to focus on the EGS side of things this evening. I just change direction a wee bit to Cleo. I mean, you gave a very good talk on appendicitis and RIF pain, which is a bigger population than just people with appendicitis. How do you think practice is going to stay changed if you like, as we come off the COVID plateau now? Or how would you like to see it?
Yeah. I found it very interesting, particularly about the fact that the patients with non-specific abdominal pain, we just don't seem to have seen. And I'm trying to work out what it is that has stopped them from coming in. Is it because they know that really deep down there's nothing wrong with them and that they don't need to be in hospital? I don't mean that, but because there is something wrong. Often it's a ruptured cyst or something. But what I mean is it's self-limiting. It's something that will get better on its own. Or is it, I mean, I mentioned the female, is it because women were more stressed being at home and doing whatever it was that they were doing and didn't want to come to the hospital, whereas the men with appendicitis actually felt their pain and had to go in? I don't know. So I'm really interested to see what happens in the future, how this changes. But I think it lends more towards the ambulatory management that we've been working towards as emergency surgeons, of these patients with right iliac fossa pain. The vast majority of them don't need to be in hospital. While you're working them up and investigating them, they can be at home and you can follow them up even virtually by telephone call. So that's what I'm hoping for the future.
Okay, and just to follow up with that, what do you think about scanning in the future? Because obviously the RIF study showed we should do it.
Sure. Yeah, I really feel that we should be imaging all these patients. It's a difficult question, which modality of imaging, and I mentioned the two ways of the US versus the Netherlands, and I think the RIFT study was used more of a scoring system to then decide which patients should then move on to imaging, and I think that is a very good option. But I definitely think we should be imaging more. Probably CT is the best imaging, but being cautious to not do too many repeated CTs, and not maybe in children. I don't look after children, so I can't really advise on that side.
Okay, and Christian and Claire. Christian first. Do you want to comment on the RIF pain and scan issue?
Yeah, we've certainly been CTing more patients for two reasons. One to identify the ones that have perforated and therefore need surgery, but also to stratify those mildly inflamed ones that we can then treat virtually. So we've been treating quite a few patients with oral antibiotics and keep their names on a virtual ward. And then our AMPs or indeed the on-call surgeon checks in on the patients to make sure that they're getting better. So we've certainly used CT a lot. Pre-COVID, interestingly, we used to use something called a limited CT, which is a very thin slice but very short segment of the RAF and pelvis, to see mostly for female patients to see if it was gynae or appendicitis. And we've not used that during the COVID pandemic, but I'm wondering whether we could do little limited CTs for patients. That's certainly something that we'll think of.
I think that's described, Claire.
Yeah, well, I think all of us will say that we've never been so quiet in our lives, and I think that reflects we've seen it all around Europe. But the number of true, surgical admissions have been down by 60-70%. I mean, my big worry is where have all the bowel obstructions gone? I have absolutely no idea. I worry that they're the ones that are dying at home and not coming early enough. I think what we've seen is that we're definitely using much more ambulatory care, where they're being seen. If they're well, they're being sent home, brought back the following day for repeat bloods and imaging, and actually managed as outpatients. And I think that will not change. I think that's been some really good practice that's kind of becoming the accepted norm, particularly for things like diverticulitis. Incredibly, we hardly now we scan them. If it's uncomplicated, they're out the door. So I think that's something that's been really, really positive. What I would say though for appendicitis is we're seeing an awful lot more people presenting with bad appendicitis, and particularly in children. They're presenting late, their families are not bringing them in, obviously, and we're seeing a lot of four-quadrant purulent peritonitis in the children, and that worries me. We actually, today, have actually done a video to tell, please bring your children to hospital if they've got abdominal pain, because these kids have been admitted and they're very sick.
I just say that we're going to hold a further ASGBI webinar on adult and paediatric appendicitis joint with the paediatric surgeons, the detailed results of COVID harem, and a paediatric trial in a couple of weeks' time, and that should shed some light and give further discussion on that. I see we've only got 7 minutes left. I'd just like to go back to gallstones, Christian. A question's come in about, can we go back to treating gallstones normally now, or in the usual way? And I guess there'll be things about PPE and resources and local infection rate. But you could maybe cover that, but just also cover something about the prioritization of the backlog. What should we do about that?
Yeah, so that's a really good question. So we're certainly pushing to restart acute biliary surgery. It's one of the things that we're seeing, the inevitable complications of not doing cholecystectomy. I think the priority should be for the gallstone pancreatitics, and we are keeping a spreadsheet of all our gallstone pancreatitics who require their gallbladder to be removed. And then the cholecystitis patients, I think I would stratify them next. We have got a significant number of biliary colic patients who keep phoning us to say, I'm still in pain, I'm getting pain every day. I feel really sorry for these people that we can't do their cholecystectomy. And I really want to applaud some institutions around the country who have really maximized the use of the private sector, the independent sector, to get day case surgery and cancer work. We've not done that here in Manchester, and I think that's one of the things that we'll look back on and we'll say we really should have explored that a little bit better. I certainly have got a lot of gallbladder patients that need their gallbladder out.
Claire, do you want to comment?
Yeah, I think in terms of prioritisation, there was the national guidance came out about how to prioritise, and in fact, gallstone pancreatitis would have been a P2 priority, and whereas normal cholecystitis would be P3 and biliary colic a P4. So, actually, what we've done as our organisation is we've been asked to prioritise everybody by those standards. Because, as you say, it's not just going to be our specialities, it's all the specialities are going to be fighting for some very scarce resources. And there's absolutely no doubt, even through optimising, we have started using the private sector in the next few days. But even doing that, we're still not going to be anywhere close to where we were in pre-COVID times. So unfortunately, there's no doubt there's going to be people waiting a very long time, and particularly with gallbladders, there's going to be an awful lot of some pretty terrible morbidity, I'm sure, because of the long-term effects of that.
Okay, I'll just take Cleo's comment. I'll just warn you that we've got 3 minutes left, and I'm going to ask you all for something that you do differently if we're unfortunate enough to have a second wave. Cleo, do you want to talk about gallbladders first, or do you want to go straight to what you do differently?
We've done a similar thing. We have been able to use the private sector to do a few urgent gallbladders, but I have found that out of 6 patients that I wanted to operate on, only 2 actually came for their surgery, because many because they were scared of having operations. So you have to convince the patient too.
I think the patients maybe knew about the nosocomial infection first, didn't they? So if we're unfortunate enough to have a second wave, Christian, in less than a minute, what would you do differently next time?
Carry on with laparoscopy.
Okay, with the kit. Yeah. Claire?
Not let the medics take all our juniors.
And Leo?
I was going to say those 2 things, so you taking my 2 points.
So, I mean, one of the things that struck me talking to colleagues was that some places have been hit by this really much worse than some other areas. And I just wonder if one of the things that we've underdone is inter-hospital staff transfer, because some areas, when you talk to colleagues, have been really quite quiet. Others have been run ragged with staff sickness and numbers. And we talked about the gallbladders, maybe the same thing could happen to the surgeons too. And limitations to getting back to normal life, in inverted commas, surgically. What do you see as the barriers? Christian?
Staff testing for us, I think, until there's staff testing, it's going to be very difficult to guarantee green surgeons to operate on green sites. We've managed to come up with rotas to do this, but they are pointless unless we can test our staff to know, or at least have some assurance that they haven't got COVID, bearing in mind that there's a significant percentage of false negatives.
Okay. And the final word to Claire?
Oh, I'd like to really come back to mental health at the end. I think that everybody's starting to really suffer now. I think maybe we don't see it in ourselves, but I think that we really have to start looking after our staff. I think everybody's done everything they can for the last 3 months, and people are exhausted. So I would say that people have to start taking some leave. I know that can be difficult because the rotas are very tight at the moment, but I think we have to start letting people try and get a little bit of normality back into their job plans as well, because this is not sustainable for much longer, I don't think.
Okay. Theo, anything you want to add?
Yeah, on the note of normality, getting back to normality is to get some elective operating, and just for the sanity of the surgeons who, with us, many of them have not been able to operate for quite some time, especially the juniors.
Yeah, the juniors are a whole different issue, and we've touched on 1 or 2 other different issues this evening. So I'd just like to say thank you to the panel, Claire, Christian, Cleo, and I'd like to thank the audience for all their questions. Stay safe, and hopefully we'll see you soon. Take care now. Night, night.